Okay. Thank you, Paul. So, Paul, if you just put up the slideshow, and while Paul's putting up the slideshow, could people just in the chat function put their title and just tell me if they will be within the PCNs, will they be dealing with the low risk asthma pathways? That would be really helpful, so we can try and go maybe a bit deeper during the discussion. Okay, so as I said before, we're here to talk about the low risk asthma pathway. Currently in BHI is probably one PCN that's looking to do the asthma pathway. I know there's a couple of practices that want to do the proactive pathway as well, but as a PCN, there's probably the people that are here. So well done. Next slide, please, Paul. So this, again, for people that have been to the meetings before, have heard that we this pathway that was set in recognition of the new ways of working post-COVID, and it's virtual by default, but face-to-face when needed. We're also looking to support the additional roles that are now based around PCNs. There's an emphasis on patient self-management and using digital innovation apps, etc., for remote monitoring. So it's the pathway is a combination of this, and you need to decide as a PCN which bits you want to take out or use all of them. That would be down to a PCN decision. Thank you. Next slide, please, Paul. So learning outcomes, as with always, as I said, this is a really, really basic pathway for generally a very well asthmatic. So you really don't need to make any changes, but re-emphasize and reiterate the educational sort of bit for the patient with asthma. So it's really understanding what the symptoms are, so you can help the patients or signpost the patient, understand what is a good control. Mohammed was going to take us through in the inhalers. Some of the triggers I think we need to recognize as well. Mostly the patients will tell you, but it's how you get that out of the patient. Understanding where to signpost these patients, so really understanding that pathway. And it makes sense as we go along. Also getting an idea of what good annual review looks like. Actually, what is it that we need to cover in an annual review? And then also be able to explain to the patients when they need to seek help. And that's all in the asthma action plan, which again, we'll refer to. So I hope that covers most of the things, but as I said, it's really, really basic stuff that we're doing today. So the next slide, please, Paul. Obviously, if anyone has got any questions, queries, you can either put your hand up. Better still, because I can't see the hand, just put the questions in the chat function. That would really help me either incorporate the question or hold on to it to answer later on. So the first bit is about Paul. I just want you to put your confidence rating in managing asthma. And I'm talking about really basic asthma. Do you understand the symptoms? Do you know the type of inhalers? Can you signpost the patient to various resources? Do you know what the triggers are? So really based on the learning outcomes, what's your confidence rating in managing asthma? Paul, I'm not sure if the poll is up. I assume it is. Paul?
Sorry, if you give me 30 seconds, I'm going to do one for you.
Okay.
So talk amongst yourselves.
Okay, that's fine. Okay. Or we could count the one from 1 to 30. Okay, no, that's fine. So I was just saying, so just rate yourself based on that basic knowledge. Can you, when you have an action plan, the asthma action plan, can you explain to the patient, what to do if they're in the green, orange, or the red zone? Do you know what other factors can influence asthma? Can you, watch their inhaler technique and tell them that is good, bad, or ugly? Or can you start thinking about actually, is this asthma, or no, you need a bit more help with inhalers. The current inhaler is clearly not working for you, so I need you to now go and see our pharmacist or our GP or our PA or whoever that may be that's dealing with the next sort of pathway. So just to rate your confidence here. Thank you, Georgina and Jaspreet, for putting it down on the chat function. And I'd encourage people, so Viren, Sajal, Tareem, if you wouldn't mind just putting down your roles and if you're going to be doing the low risk pathway. And here's the confidence rating. We'll give you 15 seconds if you could please just put your confidence level, 10 being the highest, please. And then Paul, if you just keep an eye and just let me know.
6 out of 11 so far.
Yeah, okay.
We've just had Catherine join, so you might just want to tell her what we're doing with this confidence poll.
Yeah.
It seems to be stuck at 16. Sorry, stuck at 6 responses so far.
Okay, so please can I encourage people that are here to use the poll function to just to self-rate, and then Paul, if no, people are not keen, then I'll just say let's just move on, because I don't want to spend too much time on this. It's more about you guys.
Do you want to see the results?
Yeah, go for it. Okay, so some lows and some medium, sort of 3 to 6s. That's fine. That's great. Thank you, Paul. So I'm hoping by the end of it, the poll for those that have sort of participated will also participate at the end. So Paul, the next slide, please. Thanks, Marco, Thereem, Sajal. It's really helpful. Okay. So again, a bit of self-assessment. Again, I'm not going to mark. This is just for you. Again, some may find it very basic questions because we are just doing the low risk pathway. And the question is, asthma and COPD, are they the same? I think I've lost the slide again, Paul.
That's my fault.
So just answer true, false to this, yes, no, whichever you want, and we'll go through the end. Asthma and COPD are the same thing. Cough is not a feature of asthma. Stress may make asthma worse. Eczema in the family may increase the risk of asthma. All asthmatics should be on blue and brown inhaler. Asthma deaths are rare. Asthma action plan should be given at diagnosis only. And asthma control should be reviewed once a year. So I'm going to give you, again, it's just sort of 10 seconds to try and see if you can answer yes or no to these before we move on. And just hold those responses on a piece of paper, then you can then mark yourself later on. Okay, Paul, let's move on. Okay, so another poll. I'm sorry, we haven't even started talking and we've done loads of polls. So just make sure you're all awake here. Okay, so this poll is about the use of the blue inhalers. We call it the salbutamol. So someone with asthma should be using the blue, which is a salbutamol inhaler, 8 sprays a day, several times a day, once a day at least, a few times a week, or rarely. So if you just poll, Paul, would you like to put the poll up for this?
And Jyoti, everybody should have a view here. So if we don't get 11, then we shouldn't go forward because clearly there must be a sleep actually. So
I hope they're not asleep. I'm going to start picking on people then.
I think we'll have to, won't we?
And I know some familiar faces. I love picking on familiar faces. It's my speciality.
That's good. Paul, have you got 11 answers?
We have 9 out of 14.
Ooh,
oh, 14 now. So okay, so we've got another 5 people. Tell me, Paul, if it's going up, because as Mohammed said, we really, and this is Mohammed's, so I can't, he's the author, so I can't really, I can't really deny him that.
We seem to be stuck in single figures. Oh, we're up to 10. Oh, there's been a late surge. We're up to 11 now.
That's good. Maybe the other 3 is myself, yourself, and Paul. Maybe.
No, I've made that mistake before. I'm not making that mistake again.
Well.
Okay, 12. So let's give it another 10 seconds.
That's not bad. It's not bad actually. What we'll do is, you know, like you can compulsorily mute everybody. Do you have a function to compulsorily unhide everybody so we can see the videos and see what they're up to?
Thankfully not. Right, I'm going to stop sharing. I'm going to stop.
Thank you. Thank you. If you just let us know what the poll response is. Okay, so 58% have said rarely. So, Mohammed, do you want to just hold that thought for now?
Yeah, we've got a very educated audience, so
Indeed,
that's good.
yeah.
So
We
maybe,
can pack early.
yeah, what I might say might be too basic for them actually, but there we go. That's good.
Well, we are doing the low risk pathway, so it's fine. Okay, next slide, please, Paul. And a lot of this that we are going to talk about today is going to be a recap more than anything, but also it's important that people that are not going to be the low risk understand what's going to be happening in the low risk to either signpost patients or not, more so. So you not send the inappropriate patient to the low risk group. Okay, so this is what the pathway is. What UCLP have done is they've stratified patients to 3 groups based on the asthma control test. You don't need to know all this because actually within the, we are doing group 3 now. These patients list would be on the system, which the PCNs can get out and give you and decide how these patients are going to be booked in, how that the work is going to be done. That's down to the PCN agreement and PCN pathway. But I just wanted to give you a flavor of how UCLP have used to stratify patients, which is basically using the asthma control test. It's just, it's a self-assessment for patients to see if the asthma is controlled. They use some other factors as well in terms of if they use any inhalers or if you're clinically concerned, and then the risk stratification is done. Now, I have to say, having gone through the asthma and diabetes risk stratification, it is pretty accurate. But if you do find that there are some patients that have slipped or circumstances have changed and actually they should really be in group 2 and 1, have a chat as a PCN on how that signposting will work. So this is about what the pathway is. Next slide. And I've just, at the bottom, there is a resource that people can just use to sort of link into the asthma sort of control test. Now, Paul, is the next slide, please? Yeah, thank you. So this we are expecting, and I'm not going to be prescriptive in terms of who does what, but UCLP have said the HCAs look at the low risk pathways. I know in our practice, we've kind of trained or in the process of training our really senior reception staff to be a HCA, and she's actually doing a lot of the low risk work. So again, be guided by your PCN. We've given some staff type and some intervention on the left side, but the low risk is what you would do. And the tasks to be performed are really clearly defined here, i.e. you check the inhaler technique, you signpost to education. If they're on a spacer, you tell them how to use it, you check how they've used it, the washing advice and changing the inhaler every year, etc. You tell them about the exacerbation management. So if they do get hay fever symptoms, important that they manage that. If they have put on weight, explain to them that that may have an adverse effect on asthma. So it's about that education and the symptoms and signs of asthma as well. And then you signpost to lifestyle things, so smoking, etc. Or if they're stressed, the good old IAP services. Of course, link them in the smoking cessation service. We've talked about exercise and appropriate resources, i.e. do you think they could benefit from some health and well-being support within your PCN, or have they got a back issue that's not directly related to asthma, but that's why they can't lose weight, in which case you might need to plug them into some of the MSK work or your PCN physio, etc. So just have that broad range and personalize the care for that patient. So the tasks are really clear. It's about education, lifestyle, inhaler check, etc. Okay, so I hope that's clear in terms of what your role within the green pathway are. The week after, Mohammed and I will be doing the medium and high risk, which will be more about drug titration. In fact, actually, the whole topic is about drug titration. So today it's basically the other bits about asthma. Next slide, please. And here in the digital support tools, we've given you lots of video and resources here that you can often actually send to patients. And that's really useful. And actually, Asthma UK very helpfully has got, I can't remember the numbers, but they've got sort of sheets and explanation sheets in various different languages. So it's a really good resource for patients. Next slide, please, Paul. Right. So it's not going to be surprising this to people that these are the risk factors. So who's at the risk of getting asthma? So we talk about atopic conditions. So we say people that have got hay fever, eczema, there is all an association. In fact, there's what we call as an atopic march. If the child gets asthma, hay fever, likely to get eczema. So they do go through that march. They march into getting atopic illnesses. Respiratory infection, so recurrent chest infection as a child, there's a risk. Smoking, of course, and this is where some of us don't do very well, is documenting passive smoking risk, which we should really. It's not just the person smoking, but are they exposed to smokers around them? Premature birth, low birth weight is also associated with increased risk of developing asthma. Social deprivation, again, living in sort of crowded housing, diet, lack of exercise, etc., has an impact. Obesity, we know, will make asthma absolutely worse. Now, the last bit is really important and actually often overlooked. And I would like people, when they are doing a review, to ask patients if they have worked with flower dust, paint. So there are some occupational asthmas that do require referrals. Don't sit on these people, just refer them to secondary care. And I ask these patients every year because people change jobs. So it's not just that you've asked once, but do ask them every year, are they working in that sort of environment? You know, are they working with dough, flour dough, etc.? They, you know, bakeries, etc. That will then risk them having occupational asthma, which requires referral. So I can't emphasize that point more. So here's just a sort of quick run of who gets asthma risk factors. So I'm going to just stop here and see if anybody has got any other points or any other questions on the risk factors here. And again, you don't have to ask if you are don't feel like, but you can always put it in the chat function. Yep, okay. All right, that's fine. Right, let's just move on, Paul, then. Thank you. So what are the symptoms of asthma? And again, most of you will recognize this, but a lot of other conditions also cause similar symptoms. But there are some key features that would, you know, make you think, oh, this is probably asthma. Obviously, cough, wheeze. So they typically get an expiratory wheeze. For those people that do a bit more asthma, they get an you know, when they exhale, they get that wheeze. They feel breathless. So, you know, often they would say, actually, I used to go one flight of stairs and now, you know, I've got to stop. Or they'll say, actually, I used to do a circuit and now I'm going to have, I stop because I get wheezy, I start coughing. Or I used to do 2 laps, you know, swimming, and I have to stop because I get breathless. They also complain of fatigue, and often the fatigue is also related to the breathlessness and the cough. So they, you know, because they're coughing at night, they're breathless at night, they can't sleep well, and that makes them more fatigued. Often patients will describe that the chest feels tight, so just a band. But the features here, so, you know, cough, wheeze, breathlessness could be a feature of heart problem, you know, could be other lung conditions that can cause it. But really the features of asthma is that there's a diurnal variation. That means the patient will say early morning cough, at night they're worse, they're coughing at night. So that's the giveaway generally that this is likely be talking about asthma. It also is worse by stress, believe it or not, by laughter, exercise, and viral infections. Also exposure to allergens like hay fever can cause it, house dust mite sometimes can cause it, cold air can cause it. And often I have patients who would say, when I go you know, for a run in the winter, I get really breathless, or when I'm exercising, I get outside, I'm really breathless. But I have actually seen patient, I don't know whether you've got this, but I've got some asthmatic patients who, you know, when they come in, they laugh and joke with you, and, you know, they've cracked something, and you can see them, they start coughing when they laugh a lot. And it actually happens, if you notice asthmatics, when they're laughing, they do get sort of start coughing. So just bear that in mind. And stress, of course, and stress, actually, the last 3 pathways I've done, the stress is sort of featured as the top one, because literally everything, every condition gets worse with stress. More so because when you're stressed, you're probably not even bothering taking your inhalers, but actually with stress, you get hyperactivity of the airways and things will get worse. So just remember that. But also do remember beta blockers and non-steroids like brufen, diclofenac, all these anti-inflammatory medications can make asthma worse. So generally ask the patient if it makes the asthma worse, because they, you know, cause bronchoconstriction. And if they do, do not give patients these medication. So again, I'm going to emphasize the features are cough, wheeze, breathlessness, tight chest, but typically it would be, they will say night cough, which is worse by, you know, cough, stress, laughter, exercise, viral infections, if they've got any allergens. So, you know, during hay fever time, they get seasonal sort of asthma symptoms. And obviously certain drugs, every time they take brufen, they get more wheezy, etc. So just remember that night, worsening at night and the symptoms. But equally, next slide, please, Paul, you've also got to remember that the bit I mentioned about the work. So high risk occupations like baking, or to mention about, you know, paints and flour, can also cause occupational asthma. And my typical two questions I ask are symptoms better when you're away from work, and are they better when on holiday? That gives you a clue whether it is related to occupation. And again, as I said, you need to know this because you need to, these patients really need to be referred to secondary care for confirmation of occupational diagnosis, etc. Okay, so I hope
occasionally we have had patients even working in a sort of library with lots of dusty books and offices, and there's a clear out. So
and that's why those two questions are really important, and that must be included. So okay, sorry, sorry, I've got to be about to. Yeah. So next slide, please. Right, again, this is just for information, because I don't expect you, in fact, actually, even the medium and high risk, we're not teaching them how to make a diagnosis, but it's important you know what tests are there, just so if patient mentions to you. So obviously with the diagnosis, we rely heavily on history, because if you're not even thinking of asthma, you won't even do any objective testing. So when you thought asthma, the history I mentioned to you, cough, wheeze, worse at night, etc., then NICE is recommending doing tests. So we've now got this pheno test. And actually, I don't know if Rami's on the call. I know locally we were creating the hubs to do the pheno testing, and I don't know where that's sort of reached and where that's got to, but there are plans for pheno tests to be done. Whether it's going to be PCN based or a hub doing it, I don't know. And the pheno test is, if you suspect asthma, you can send them for a pheno test, following which they can also have a spirometry, which stopped during COVID times, but they are going to restart. And with spirometry, they do what we call as a bronchodilator reversibility, because asthma, you can reverse when you give, bronchodilators. The narrowing of the sort of the airways is reversed by giving certain sort of steroids or inhalers. And that's what we check for. And that's typical of patients with asthma. Okay, so there is reversibility, spirometry, and of course the peak flows. And I've put some pictures here. The lady on the right, so I couldn't find the UK type of, the ones that we use here. I found this really fancy one, but it's probably a USA picture or something. I don't know, but I couldn't find the normal one. But anyway, this is just to let you know, history suspected, you need to then do objective tests to confirm the diagnosis. And actually, NICE is saying patients from the age of 5 should have objective testing, which actually is very different from when I trained. And when I trained, it was mainly just rely on the history, give them inhalers and see if they get better. If they do, great, that you got asthma, and then just give them a peak flow reading. So it's now really changed to say, no, we are over-diagnosing, or in some cases under, we need more objective testing and more testing. And I'm not going to go into the details because not for this group really. In fact, actually testing, I don't think Mohammed will cover in the other, because that should be, it's a completely different topic, different, different area. But just to let you know, the objective testing are 3 main objective testing after pheno, which is spirometer, bronchodilator, and the peak flow, they blow into that sort of meter to check what the readings are.
I don't have a picture of that. I can show you one. You just blow
Yeah.
it
Oh,
up.
yeah. There you go. Well done, Mohammed. Yeah, that's the one.
That's a cheap and cheerful diagnostic tool that you can prescribe and can be
Yes.
used and can be quite helpful actually. So
Yeah.
in
Yeah.
these COVID
Thank you,
times.
Mohammed. Thank you for that. I did say he was the asthma guru. I've got nothing lying around here but the slides. Okay.
Plenty of stuff.
Thanks, Mohammed.
And
Thank you.
everybody who hasn't said who they are is going to be tested to name all these inhalers actually. So we have only had 8 out of the 14 say who they are actually. And
Oh, no,
it's
please put your name. Yes, maybe I think they came later and they didn't probably hear. So please kindly put your name on the chat function, and any questions on the chat function as well. We will take them as we go along or save them for later.
So far, just to give you a flavor, Jyoti, I hope I'm not disrupting you too
Not
much.
at all.
As Imran would have told you, I'm very disruptive, but we have 5 pharmacists, we have 2 healthcare assistants, and 1 health coach, actually.
Fantastic.
And 2 nurses, So that's
Okay, yes, that is really, really good. And as I said, I mean, even any knowledge, even basic, is a refresher. It's a good refresher. Okay, so next slide, please, Paul. So this was just a really brief overview of the diagnosis. Now, I just want you to look at some of the other things if the patient mentions to you, which even if they've got a diagnosis of asthma or you're considering a diagnosis, which would make you think actually they might not have asthma, they might have something else. So if they're losing weight, they're failing to thrive. So we're looking at things like if they've got an adult losing weight, it could be cancer. Failure to thrive, it could be a child with cystic fibrosis presenting with similar symptoms like cough, a lot of mucus. Excessive sputum, again, cystic fibrosis, but COPD patients are slightly different to asthma. Obstructive nevertheless, but there's a bit more damage rather than inflammation, although there is inflammation in COPD, but it's slightly different conditions. So you're looking at a smoker, elderly smoker who says he coughs in the winters, and that could suggest probably COPD rather than asthma. And they come and tell you, actually, I'm coughing all the time, day, night, equally. The symptoms are not variable. You're thinking probably not asthma. If they say we're coughing up blood, you're thinking actually it could be TB, it could be cancer. So you're thinking of other diagnoses first. If they've got a temperature with a cough, you're thinking again, they've got some infective condition rather than asthma. A lot of patients who have got anxiety can complain of tingling in the hand. So just check for that if they've got sort of tingling and they also cough and they feel they can't breathe, but that's actually anxiety. And people with heart failure often present with a cough, wheeze as well as leg swelling. So just bear that in mind. So when you are, and I think for you, the most important thing is that they say actually they've got no variability in the symptom. You're thinking, and there's no triggers. So when they exercise, the cough is the same as they don't exercise. You're thinking actually possibly not asthma. We need to rule out other things before we say this is asthma. So just wanted to put this out there in case you see a patient who's come for an annual review and he starts saying, oh, I'm coughing up blood, or I've got a temperature, or I'm actually getting leg swelling now. It's not asthma. There is something else happening, and you need to then signpost these patients based on your local PCN pathway to the relevant clinician, whoever it is. So just bear that in mind. Any questions so far? I'm going to chunk and check at this point. So what we kind of have covered is what are the symptoms of asthma. We've covered some of the, diagnosis really. How do you diagnose? I've also then told you what are not the symptoms of asthma, which is here, and you need to consider other things. And I've just told you about a bit of the risk factors, and particularly the emphasis on the occupational bit as well. Okay, so no questions. The chat function is going to move on. Okay, so this is where I think you need to probably all wake up and start listening now. So far, we were just doing a bit of background, but this is now something that you guys would be expected to do. So we want patients in your group will generally be well controlled, and to confirm that they are well controlled, we need to define what good control is. Okay, so by good control, we mean they have no daytime symptoms, they do not wake up, the asthma is not waking them at night, They don't take any rescue medication. So, you know, they don't need to. So they decide they're going to go for a run today. So they start taking their, inhalers. So actually there is no need for that. They're absolutely fine. There's no asthma attacks. There's no limitation on exercise, and there's no side effects. So this is what you would be checking with the patient when they present to you. And if any of these are negative, i.e. they say, no, actually, I have daytime symptoms, you then need to signpost them into the other pathways, because they might need a review of the inhaler, or they might need an add-on to the inhaler, etc. So they need something else done, essentially. And to do this, you don't have to ask them these specific questions. You can just send them the ACT, so basically this is the asthma control test, and that is a questionnaire the patient can send back to you, and that would give you a score, and the score tells you that actually it's not controlled, or it's very well controlled, or really bad. So you need to then signpost this patient, but hopefully all the ones you would be getting would be saying the control is fine, there's nothing to do. Everything is normal. But if they say that it isn't, you may need to do lung function tests if you feel, lung function tests usually a diagnosis, but you may need to do that if you feel actually some of the asthma and COPD is overlapping. You may need to repeat the lung function test, but not on a yearly basis. However, you may wish to check the peak flow. So peak flow will tell you if there's a variability, if the control is fine or not. And if there's a lot of variability, they've confirmed that they are still getting symptoms, you need to shoot them into the other pathway. Okay. So reiterating again, good control is literally no symptoms. They are well, they haven't been to the hospital, they've got no symptoms at all, essentially. And to assess that, you will be doing an ACT, which is the asthma control test. I'm hoping the PCNs will decide. And I know there are different ways people do it. So certainly in our practice, we send this control test to the patient, and we then look at the responses. We then prioritize the patients that say that, that the control isn't good. And then the low risk then go to the low risk pathway. So that's how we do it. But again, be guided by your PCN pathway. We also ask patients to send us their peak flow reading morning, afternoon for a couple of weeks. So that gives us a good idea of what it is, but more so also it reiterates the point to the patient as to what their normal peak flow is. And I actually get surprised when I started really enjoying doing asthma checks, which was about 5-6 years ago. I started realizing actually a lot of patients don't even know what their peak flow is. They've never even done it except the time when they've actually come in for an acute episode. We've going to blow, and you say, well, what's your normal peak flow? Okay, no idea. So you think, actually, how do I compare this, because this might be normal for you? So actually it's really important you recognize, particularly at diagnosis, and reiterate what their normal peak flow is. So when they are well, they've got no symptoms, they can blow in and do the 3 times, and the best would be their normal sort of peak flow. And that's what you would use as baseline to assess whether their sort of symptoms are getting worse or not. Okay. So I'm going to stop there and ask and see if there's any questions. And see, Mohammed, do you want to add anything at this point?
One thing that I would add is that don't ask the patient how well controlled your asthma is, because they have a completely different perception. They feel it's okay to be getting symptoms and it's part of their condition. So, and another test, if you don't have a chance to do an asthma control test, is just ask them how often are they using a blue inhaler, because that itself will trigger off and highlight that the control is not there. And in case you don't actually have a chance to do the full test itself. Yes.
Yeah, and that's a really good point, Mohammed. So if you do see a patient ad hoc as well, you could just ask that one question, how many times you use the blue inhaler. And if they're saying to you it's on a daily basis, then you know that there is something not right, the control. And then you can go into full-blown testing and asking other questions as well. And Mohammed, you're absolutely right. The patient's perception, and I think partly it's our responsibility as well to let the patient know that a good control is nothing. No cough, no symptoms at all. And partly maybe we don't convey that to the patient well, and they just think because they're asthmatic, they've got to live with this cough, or they've got to just have a bit of cough at night and wake up. That's quite normal, and they shouldn't be exercising. So you're absolutely right. And it is that personalization touch that you then add to the patient. So no, great point, Mohammed. So the next slide, please, Paul. Okay, so this is what I think perhaps Mohammed was also sort of saying, that one of the other things you could do or see that the patient would require step up in treatment is if they're using the short acting, which is the blue inhaler, 3 times a week or more. Do you have asthma symptoms 3 times a week or more? Are you woken up at night once a week or more? And that would tell you the asthma is not controlled. As I said to you, any symptoms of asthma, cough, wheeze, breathlessness, tight-chested in a patient is not, it suggests it's actually the control isn't there. And these patients would require stepping up the treatment. So just push them into the yellow or the red pathway, depending on the symptoms. And also just to reiterate that actually also what is not normal is for patients to have steroids. So every time they have steroids, an asthma attack, it's time to reconsider and rethink whether the asthma is actually under control, and then to consider whether the blue inhalers is sufficient, or do you need to add the next step in the treatment for asthma. So again, just pointers, because you will be seeing these patients, and you will be asking them these questions, and these are just some pointers that would suggest to you that actually control is not quite there. And two ways you can do it. You can ask ad hoc patient sitting in front of you who says asthma is okay. You just ask them how many times they use a blue inhaler, or you can actually signpost to them these 3 questions, or you can do the asthma test, the control test. There's RCGP one as well, the 3 questions on the RCGP. Anything that will just give you that further information on the no. So everything should be no, is what I'm getting at. Okay, so the next slide, please, Paul. Right, Mohammed, is this where you take over?
Yeah, just for a short while till you come back, actually.
Okay.
So now, just to mention to everyone that I very much planned this in the expectation that we would be having mainly healthcare assistants and health coaches and social prescribers. So it's a bit basic. Apologies for that, but hopefully it will be a very basic refresher for everyone. So effectively, we start with a question, and we won't move forward. This is not a poll, it's actually a question, so I want to see people answering. So inhalers essentially do one of 3 things, although there's so many different inhalers, but they do one of 3 things. What are these 3 things that they do? 3 classes of inhalers. And let's see some responses, see if everybody is still awake and listening. No responses so far. Well. It was the thought of me presenting has put everybody off already. Dilate the lungs. Okay, that's fine. Rachel, thank you so much for starting it off. Anybody else? Prevent asthma attack. Well done. Wow, Rachel, you're on a roll there. Open up airways. Yes, that's one of the things. Prevent asthma attacks. Anything else? 3 things. So we seem to have identified relieve these, okay, which is around opening the airways. Okay, that's fine. Relieve the stress. Okay, that's fine. And breathlessness. Okay, that's good. Todd, thank you very much. Very proactive. That's good. Yeah, anybody else? Any more? So reduce inflammation. Good. So effectively we see, yes, deliver medication to site of action directly. Okay, that's fine. Relieve tightness. Okay, so yeah, one thing clearly you all identified is that inhalers offer relief. They're reliever inhalers, which is the blue, the salbutamol ones. We've got the other inhalers, which are effectively preventers. And the third thing that I was looking for, which was a bit of a trick question, is we now have inhalers that do, oh, Paul, sorry, we'll have to go on to the next, not the same slide, but give the answers. Sorry, Paul, I'm forgetting, I'm trying to click. Yeah, so you've got the blue inhalers, you've got the brown and other colors, which are preventers. So it's no longer brown, it's other colors as well. And then you've got the one that I absolutely adore is the smart inhalers, which are both relievers and preventers. So sometimes if you see a patient and they don't have a blue inhaler, that's great, because they're probably on a MART therapy, which means they're on a combined reliever and preventer inhaler together. Okay, so we'll move on to the next slide. Right. So again, very basic for our audience, but you've got the blue salbutamol inhalers, which is basic, short-term relief, but it doesn't address the underlying issue. So anybody using their blue inhalers, salbutamol, more than a few times a week needs something else, needs to tackle the inflammation because you're tackling. Now, at this stage, we need to be very clear about the difference between asthma and COPD. In COPD, they should be using their blue inhaler regularly because with COPD, it's irreversible. There's a degree of irreversibility. They can use their salbutamol up to 8 puffs a day. It opens up the lungs. Again, hopefully we can give them other inhalers as well to make them less breathless. And there's a different form of looking at their control. But with asthma, they should really not be using their blue inhaler more than a few times a week. Yeah. You've got the brown inhaler, which is the steroid, which reduces the inflammation, prevents breathlessness, like you've identified. But what you have is a lot of combination inhalers. So the majority, there's a lot of inhalers that are combination inhalers. These combination inhalers are a combination of the steroid inhaler and a long-acting version of the salbutamol. They are used on a regular basis, and what they do is hopefully they clear inflammation and also keep the airways open for 12 hours rather than needing the salbutamol all the time. Again, the combination inhaler should be used regularly. Steroid inhalers used regularly. The salbutamol to be used only as and when the symptoms occur. Okay, we'll move on to the next slide. Right, now, devices. Favorite topic. There are loads and loads and loads. And these are not all of them. There are new ones coming out every day, basically, devices. But we can categorize them into just 3 types, despite the number of them. So what are these 3 types of devices or classes of devices? Dry powder. Okay, so we have somebody mentioned dry powder. I'm not saying whether it's right or wrong. Any others? Any other thoughts? Got an audience of all some pharmacists, nurses should be able to come up. MDI. So MDI is a metered dose inhaler. Anyone else? Any others? Or are these correct? Anybody want to put down any other devices? Dry powder, MDI, aerosol. Yes, so an aerosol is an MDI, metered dose inhaler. So you can call it either aerosol inhaler or an MDI inhaler. Well done. Sejal has come up with soft mist inhaler, and we will cover that as well. Any other thoughts? Anybody feel that there is more than these types of inhalers? I think we have identified those 3. So Paul will come up with the 3 answers. So effectively, you've got the puffer, the normal one. You see people in the underground trying to actually breathe very quickly. And you've got the aerosol inhaler, which is the MDI. Jasprit's made the point, breath actuated. So breath actuated come in 2 sorts. You've got dry powder breath actuated inhalers, or you've got something like Cuba Easy Breathe, which really is an MDI. Or you've got the Flutiform K inhaler. Again, it's an MDI, a monitor dose inhaler with a special mechanism that's triggered when you actually breathe in. So in reality, it's an MDI. Yeah, so you've got monitor dose inhalers, you've got dry powder inhalers. And the thing with dry powder inhalers is there is no squirting. You have to generate the inspiration to get that into the lungs. And then you've got the soft mist inhaler. This is a newer type. Unfortunately, there is not many compounds that come with this. For example, you can't get salbutamol in this particular inhaler. And this is quite nice because what happens is it's a soft mist. It's a bit of a pain to make up. But once you have made it up, it's quite easy because it generates a soft mist. It's very easy to breathe in, but it's getting enough compounds in there, enough molecules in there, and also sort of the making up exercise can be a bit complicated. Yeah, so 3 broad types of inhalers despite all the different types. We'll move on to the next slide, Paul. All right, so interesting now. This is a poll, and let's see how many have managed to stay awake. So which percentage of patients use their inhalers correctly? 10%, 20%, 30%, 40%, 50%, So we can start the poll if we are ready.
Apologies, I've been logged out for some reason, so I'm going to have to try and launch the poll.
Okay, so Rachel's come up with 10. Thank you very much, Rachel. Again, whilst we wait for Paul, you may put it in the chat function. Interesting. I should have asked how many healthcare professionals get it right. And we normally run, so 30%. Georgina is being, no, we'll go back to the, oh, not just yet. 20%, right? 10, 20%, okay. And please feel free to don't you feel it's 50% the amount of inhalers we give out, and it's only 30% and 20% of patients use it properly? Where are we going wrong then with this if it's so low? Well, we'll give you a minute or so, and then otherwise we can always move on. I can. No,
I think continue to use the chat because for some reason I've been signed out of the account, so I can't run the poll at the moment.
No problem.
Apologies. Sorry about
that. That's fine. Yes, so the answer is under 10%. Yeah, under 10%, and even healthcare professionals as well. A lot of them don't get it right actually. So yeah, it's under 10%. So it's very important inhaler technique and how inhalers are used. And if nothing else, those of you who are not going to be managing asthma, etc., just watch the patient use their inhaler, especially their MDI, meter dose inhaler, because you can refer them and you can give them a few tips that would really help actually. So we'll move on to the next slide. Right, so what is good inhaler technique? Now, there are some videos there. We'll see if Jyoti wants to display them. But before we go on to those, slight problem with the videos, etc., is they give 7 steps and 5 steps. Slight problem in practice is the patient will not remember those 7 steps. All they'll remember is, and I see it, normally they come in and they will shake it, and that's great, and that's about all they do right, because that's the bit that they remember. So I think inhaler technique has to be very much matched to the patient. How much they're going to take in, how much they're going to absorb. Rachel's made a very good point that, they forget. And they, so we give them the points that are the most critical points for using the device. And of course, good technique can include a lot of other things, but maybe we need to start with absolute basics. So, of course, almost everybody is going to be on the sub. Yeah. And the problem with this is how they use. Now, the problem with the salbutamol MDI, and of course, there are a lot of other inhalers that come as the meter dose inhaler, the aerosol inhaler. And what happens with that is it's fast. It's very quick. I hope you can see. It's really quick. You want to get it into the lungs. And what you'll observe, the typical patient who is doing it will just go. Yeah, here you can see. And or what they'll do is they'll be there. They'll be like waiting here. And then it will like be a big wait. And then it'll be that sudden thing, basically. And then straight away. That's the typical. And if you're lucky, they'll keep their mouth closed. If you're unlucky, the mouth will be open. To be honest, they're getting 1 or 2% of this salbutamol in their lungs. And hence, they're ending up using so many puffs a day. How to do it properly? It's difficult. It is very difficult to get and use this MDI properly. Even if you use it with perfect technique, you're going to get about 10% of what's in there into the lungs. Now, one way to teach patients how to use their inhalers properly is to use this lovely device, which is called a Flowtron. And a Flowtron is prescribable, underused, I'm afraid. When I still ask for it, people still say, what is this? It's a lovely device that fits into the MDI. And effectively, what happens is, the idea behind a meter dose inhaler is not to just puff it and it will mysteriously get into the lungs. You have to start to inspire, press, and continue to inspire. So effectively, this aerosol is being carried into the lungs rather than end up in the mouth. The advantage of a flow tone is it makes a noise when you have reached the right inspiration. And it also shows you if the patient is using it properly. Otherwise, it's very difficult to know when they do this. Have they got into the lungs? They've not got into the lungs. You've got a fair idea that they haven't. But it's always good to have these. They're cheap, £2 for a pack of 2. And the idea here would be, so I'll just observe this and try it. So what happened? The noise came, the inspiration was there. I pressed it and I continued to breathe in to try to get it into the lungs. So what the typical patient will do is they've already pressed it, it's gone in the mouth, then they're breathing in. Or the other patients will go that, or they will do a nice deep breath and press it at the end, by which time they've run out of breath to get into the lungs. So it will go afterwards. Yeah, so that's a wonderful thing. But what we really need to do is the greatest gift that you can give anybody with asthma is, number one, no matter who you are, is just ask them to show you how they use their inhaler. If they show you, you know it's not right. And then you can at least advise the practice to give them one of these spaces as a minimum, besides a review as well. That's something. And this is the most wonderful device that you can have, because what it does, the spacer, with the spacer, problem is carrying it around. It's not as big as it looks. The advantage of the spacer is that you can get 30% deposition and it holds it for you. So you don't have to worry about the speed. You don't have to worry about the coordination, and absolutely brilliant. So what happens when you use the spacer is effectively none of that coordination required. This is an aero chamber. I think it's probably the best spacer that you can get, because it comes with it's a flow view aero chamber, and it comes with its little lever here, so you can see when the patient is breathing in. Yeah, and the idea here would be that no coordination required. You press, then you breathe. And ideally, if you can get patients to take 5 deep breaths, the way to explain to patients is, look, you want to get it in the lungs. You don't want to get it in your mouth. The idea is this is holding it for you. Taking 5 deep breaths will actually get it in. So it would be, put it there.
I've just stopped sharing the slide just so people can actually get a better view of you doing that. I think if people can choose on their view options, the speaker view, you'll get a full screen picture of Mohammed sharing that technique.
Yeah. So 5 deep breaths if you can. Now, a lot of people are not going to carry this around with them. Try and convince them. A lot of people will not have time to have 5 breaths, but you can try your best. And again, just observe people, see how they're using it, suggest to them to use their spacer, ask them why they're not using a spacer. Very important to use a spacer. So that's MDIs. Ideally, we don't want to give anybody an aerosol inhaler without a spacer. I'll give you a story. Just saw somebody on Saturday. They'd been to the actual specialist respiratory nurses, but nobody had actually tested the technique. And the technique was so poor. Another story, we had a patient who was unstable asthma, been to the specialist, was about to be started on biologicals because every therapy had failed, but nobody had suggested. And in fact, that patient still comes in and says, I'm going to take this to my consultant and show my consultant how to do this. So sometimes the very obvious things are ignored, and don't assume that they've tried a spacer or they use a spacer. Yeah, so take home message, best gift you can give somebody with asthma.
Mohammed, I had a patient. This is a patient who was asthmatic for 5 years, and I asked him to show me the technique. He gets up, puffs in the air, and walks through it. So I thought, no, he's kidding. There's no way. This is a patient 5 years, new to the practice, and I was so shocked that actually nobody in the 5 years. And he had come that he just couldn't, breathe. And clearly it was, everybody else was getting relieved around him in the air, but yeah, I mean, I laughed at the time, but I felt really sad that actually no one in the health profession had bothered to see what he's actually doing. Really sad.
Now it's nice that we've got a bigger team. So hopefully everybody participates in it, and just in fact, just ask them to show. And then something like this would be spotted, basically. Yeah, we can assure you there's no inhaler that even the soft mist inhaler, by the way, I showed this to you, you don't actually walk through it. Yeah, it's in the mouth and it needs to be created. You can, for those patients, I mean, nobody's going to use this, potentially a very elderly asthmatic or somebody with dementia, you might give them the mask, you put that over. So the second class of inhalers, and again, Paul, we don't need the slides, are the dry powder inhalers. Yeah, so you've got these, you've got different inhalers. Now, with the MDI, the idea is to take a slow and a deep breath. With the dry powder inhalers, there is nothing, I mean, whilst it has one of these, it really is, you're going to generate enough inspiration to get that into the lungs. And effectively, generally, you don't use dry powder inhalers with salbutamol, with the combinations, with the steroid, yes. And effectively, with this, you generate the force. Now, different ones of these, so effectively, this is a nice one because it actually, Foster and exhale, it actually makes a click. So you know the patient's had it, but not all of them. You see a click there, but there are plenty. That's an AccuHaler, quite commonly used. But again, with an AccuHaler, there's no click. An elliptor device, again, very popular, but no click. So you don't know if the patient's had it or not. You don't even know if the patient has enough inspiration to breathe it in. So normally what you would do is, this is an in-check device. This device tells you if the patient has sufficient inspiration to be able to breathe in one of these dry powder inhalers. And different dry powder inhalers have got different resistances. So you can sort of judge whether the patient has the right thing. Now, the soft mist inhalers. Soft mist inhaler, a bit of a pain to make up, but once it's made up, it's a nice soft mist that comes out. It's already sort of reacted before it's supposed to. And again, the idea would be to prime it in the mouth and breathe it. Your mouth is acting as a spacer. So those are the three types. Paul, we can go back to the presentation now. Wonderful. There are videos as well there, which you can advise patients, etc., but nothing better than observing it and watching them do it and demonstrating to them and making them do it. Sometimes it takes several visits before they get it right. You show them, they forget, and then you show them again and see how they're doing it. And if we move on to the next slide. So good news, we're running some face-to-face workshops. And these were originally just for PCN pharmacists in Havering, but they're undersubscribed. So the opportunity is there for any of you to join. They're being run by our team, and we go through all these devices, and it complements the medium session. So don't all not attend the medium risk session, because that's more about treatment. This will be just about inhaler devices and the different use. Paul's going to circulate the flyer for this, and book early because there's only limited places there. And I think that was everything I had to say. I wonder if there are any questions on devices, inhaler technique, etc. And sorry, Jyoti, I've taken up so much of your time.
No, Mohammed, that was absolutely brilliant. And I think it's really helpful for people to actually know which are the type of devices, particularly how they work, because the patients would just come and plonk them on the table, isn't it, and say, well, this is it. What do I do? So it'll be really, I think this session would be absolutely brilliant. As you're saying, it probably complements any of the asthma pathways, and you require more time really. So 3-hour workshop, that's amazing actually. That'd be really good. And
you
I know
get to play with them as well. You get to play with them.
No,
and you get tested as well.
No, well, don't put them off now. So, I mean, I know last time when I attended this workshop that was run, I can't remember, a couple of 2-3 years ago, you gave a really good sort of a visual aid of different type of inhalers and how they work. And I think that would be really nice for people that don't prescribe it, you know, all the time. It might be something you want to just take back to the medicines management team. It was really good visual guide. Okay, so no questions for you, Mohammed. You got away easy there. Nothing on the chat function so far, but please do keep the questions coming, because we can always address them as we're going along towards the end or however. Okay, right, Paul, should we just move on to the next slide, please? Right. So I just wanted to really do a brief introduction. Again, this is not what you guys will be doing, but just so you be aware. So when a patient gets diagnosed, what happens, just the patient's journey, and actually what does a clinician do before then they come to you to go into the list of managing them annually. So you would do a baseline. So you would do a asthma control test, you would do lung functions at diagnosis, and you'll do peak flows. And I've mentioned this before, peak flow primarily to understand what your baseline is, the asthma control test to understand how good your asthma control is, clearly not because that's how you get diagnosed, I assume. And then the lung function test is look for the, the FEV1 as we call it. So there's a special level that we look for in the lung function test, and the obstructive picture. Not going to go into the details. You just need to know spirometry is part of that baseline. Obviously, education is really clear and important, and it's nice to explain to a patient in a very basic layman's term what asthma is and how to recognize a flare. And how to recognize a flare, I've told you, no symptoms at all. No cough at night, no wheezing, nothing really, no symptoms, just feel normal. And but if you go on to patient.co.uk, they've got some wonderful leaflets in a very patient-friendly layman's sort of language on what asthma is. I find there are a lot of health beliefs floating around on asthma and the use of inhalers. So do try and address them for whoever's doing the diagnostic workup, because unless you do, the patient's health beliefs will guide whether they take the inhalers, whether they do anything with asthma at all. Only for you to know 5 years down the line that they didn't take it because they believe that the inhaler has got some special molecule that will destroy them or whatever. So just be guided by that. Obviously, you'll have to go through IMS, the flu, people that require pneumonias, shingles, whichever flu jabs that will require, obviously COVID now as well. You will discuss triggers and avoidance. Actually, my experience, most of the patients tell you that. So they will tell you, hay fever, is it the dust? Is it when they get viral infections? Because those are the triggers they've got to try and avoid as much as they can. Obviously, they can't avoid every viral infection, but they can avoid smoking. They can sort of avoid other bits. However, also, if there are other triggers like, pollens, etc., they might benefit from antihistamines, particularly if they've got seasonal asthma. So you need to try and reduce the sort of that hyperactivity of the lungs to try and then reduce the asthma symptoms. That needs to be sort of treated together. Smoking, I'm not going to say more because everyone knows how important that is. I mentioned to you about obesity as well, and do bear in mind that people can now be referred to digital weight management programs. So it can be a digital, which is why I said the pathway is looking at digital, but equally you can refer to exercise and prescriptions. There are drugs for weight loss like Xenical that some patients may benefit from. So understand and agree what the obesity pathway within the PCN is, because weight loss would help, and it is one of the triggers really for patients. Always signpost to Asthma UK, and as I mentioned, there's actually very helpfully leaflets and asthma management plans, etc., in different languages. That would be really useful to the patient and you. And obviously, we've just gone through how important the inhaler technique is. Also, I say to the patients that I explain to them how they can order the inhaler. And if they do order it frequently, that would trigger a call. And I know there are some issues with the local pharmacists ordering, and that's something on our radar. And as part of the educational offer, Mohammed, I think perhaps we should need to include the community pharmacists as well, because I think that we need to sort of co-produce and co-work to try and minimize the request there. But do tell the patient. So now every time I'm diagnosing, I'm saying to the patient, you request an asthma inhaler, you're going to get a call from us if it's not due to be requested, essentially. So the asthma, so really they shouldn't be requesting every month is what I'm saying. The asthma action plan, really key and crucial. This is about self-management. Remember I said to you right in the beginning, actually one of the USLP pathway is self-management, digital, and utilizing the new ways of working, so remote and sort of face-to-face. So the action plan gives the responsibility in the patient to recognize the signs and symptoms and to get help based on that. And we'll just address that in a minute. So, and then also I mentioned occupation. Sorry, Mohammed.
Just one way of addressing the overuse of salbutamol and changing patients' perceptions is to in fact refer to the salbutamol as an emergency inhaler rather than a reliever. Reliever implies it's relieving, whereas emergency is something's gone wrong and you're using it because you've got breathless and you shouldn't be getting breathless. So there are certain clinicians who are calling it emergency inhaler.
And I think that's the point that I also made earlier, is that if you as clinicians know that a good control is no symptoms, then they shouldn't be using no inhalers as well. So essentially, you need to convince yourselves that that's the case, in which case you will convince the patient to say, actually, they do keep ordering salbutamol, then there is something not right, albeit whoever's ordering on their behalf. There's something not right, and we need to reconsider, re-look at the plan and management plan. So you're absolutely right, Mohammed. Thank you for that little tip. So this is what happens when somebody gets diagnosed. So just to recap, you suspect from the history, because there are, there's variation in the cough, the wheeze symptom at night, you're thinking probably asthma. You will do some diagnostic tests like the FeNO test, like the spirometry, the dilator, reversibility, the peak flows. Along with that, once you've diagnosed, you'll do all this, okay? This is at diagnosis. Because this is what good control is. Apart from the education and inhaler technique, you will do everything else as well. So next slide, please, Paul. So this is what happens at an annual review. Pretty much what you've done before is what you can revisit. But as I said to you before, you can use the asthma test, asthma control tests questionnaire or RCGP questionnaire. And again, you'll need to decide as a PCN what that pathway is, whether the patients would be sent through or how you do it would be down to you guys as a PCN. So speak to your PCN leads about that. Anyway, once you've got that, this patient's got really good control. That's why they ended up in your list. You will then need to check, because despite them saying now, there's nothing wrong with me, I'm absolutely fine, I'm not waking up at night, you need to check, have they had any hospital admissions? When was the last flare? Are there any new triggers, any admissions, and the use of the blue inhaler? So often those are the things that are as an add-on to the RCGP question, although a lot will be covered by the asthma control test. Obviously check smoking, weight, compliance, technique, and repeat inhalers. So I always, as part of the annual check now, see how many times have they had the repeat. Are they using, are they requesting it when it should? Or are they under or over? Because a lot of time is also under. I've said to you this before, recheck their occupational. Are they now working in that high risk sort of occupation that may make their asthma more occupational asthma than anything else? Now, NICE also says you assess the risk based on that, and I'll cover that in the next slide, but also check the steroid use. And what they've defined this is if you use 3 to 4 times a year, which I think is an overkill really, then they're overusing it. But if they have used it, do remember that the steroids can cause side effects. So if you've got an asthmatic who tells you that they've used the rescue packs 4 times a year, they need to have the blood pressure checked. It could affect the bones. You need to have an eye test because that could cause glaucoma. You need to ensure that they get diabetes and cholesterol checks as well. So this is all nice guidance saying just check the oral steroid use. And if they had that, then you need to make sure they haven't got any side effects from the steroids. So this is something the low group you need to be aware of. I'm not asking you to do the checks, but you need to just see if the rescue packs have been used more than 4 times. You need to let the other sort of pathway people know that that's happened, and then they can keep an eye on that as well. Just do remember that NICE is now recommending patients can have oral antibiotics for 12 months if they have recurrent flares. So again, it's not, I'm hoping somebody that you would be sitting on your list. However, if during discussions they mention to you that they are getting recurrent infective episode and they constantly take antibiotic, albeit whether it's been given, in the right diagnosis or not, you need to then consider whether they will benefit from oral antibiotics for 12 months. Again, not your decision, but just you need to signpost. And of course, Mohammed has nicely mentioned, for those people that are really not getting it right in terms of the inhaler, consider spacer. In fact, I've got more tendency now to prescribe spacers for most of my patients than not. I just assume that everybody is then less than 10%. So I actually tend to prescribe a lot of spacers to my patients. But again, just be guided. And then that's where personalization comes in, because it is a gadget to carry and take. So patients might not want it. So that is personalization. So I just wanted to put it out there. So again, annual check, you're checking control, and the answer should be no to literally everything. Along with that, you're checking not just now, because a patient who's been well in the last month may actually say, yeah, I'm absolutely fine now. But actually they've had, 10 admissions to the hospital with asthma flares, or they've, or they keep getting blue inhalers. So you just need to get that sort of wider questioning, even if they've answered that they're fine now. Smoking, absolutely. Technique, absolutely. Check how they're getting the inhaler, how many they're getting, and occupation. Check to see if they've got recurrent antibiotic use. Would they benefit? Signpost. And if they've taken a lot of oral steroids as a rescue pack for acute flares, then you need to just signpost to say that actually they might need some support. Just checking any side effects of steroid use. Okay, so I'll stop there and chunk and check there. So any questions so far? Nothing there, but Rami, you mentioned the KEGG template. The KEGG template is really useful, Rami, but what it doesn't cover is these personalization bits that I'm just mentioning here, particularly around the, and this would be more relevant really for the medium and high risk in terms of the steroid use and antibiotic, although it's a very good template, but I still need people to be asking about the other questions in terms of the hospital admission, triggers, inhaler use, etc. So that's really helpful. Thanks, Rami. Rami, while you're here, can I just ask, I was checking about the pheno testing. I know there was a discussion about pheno testing. Is that up and running now, or is there plans? Rami? Okay, Rami's gone again. Rami, when you're back, please answer this question, because I want to know for the medium and high risk group as well when that's going to be launched. So next slide, please, Paul.
Hi, Jyoti, can you hear me?
Oh, I can hear you now, Rami. Yes.
It was breaking up. Sorry, can you repeat it?
So Rami, I was asking about the pheno testing. I know there were discussion about having the hubs, and how is it going now?
Pheno is up and so I think what you call the barking diagram is the first one who's trying to get into it. So once it is fully, I will give you an update on the other two as well. And even the barking, the diagram one, I will confirm too. Like, to be truthful, I need to see it in black and white. I will speak today only with Shivani and confirm with you guys. But pheno is part of, in all the three areas when they set up it, the advice or the request is to have that service available for pheno.
Okay, that's really helpful. So can I just ask, Rami, are we looking at a diagnostic hub, or are we looking at two separate sort of pheno and spirometry services?
No, it will be part of as spirometry. So it would be, I think, I don't know whether it is to put a line and class it as a diagnostic hub, or because I think there could be moving on towards, would any of the PCNs be interested? But I think that's a bit more political, like from our point of view. So at the moment, I think it's the federations which are coming forward to provide this service. And moving forward, I would leave it a bit open.
Okay, that's really helpful, Rami, because I think it would help the proactive pathway, the low, medium, and high risk pathway understand the diagnostic criteria as well. So whenever the service is up and running, I think it would just help do a bit of education around that, because there are certain categories of pheno, isn't it? People that need peak flow, people that need spirometry or whatever. Is that okay?
And I think that's the reason, because they need an accreditation moving forward for spirometry as well. And
yes.
Also then we know pheno negative doesn't mean always it rules out
1
asthma.
in 5. Yeah, 1 in 5. Yeah.
So it has to go with the history as well. So, but I will update that today only. I will ask Shivani to send an email so that we have it more in black and white and confirmations as well.
Thanks, Rami. So that's really helpful. So just to remind guys, the pheno testing, I was saying that it was part of the diagnostic. So if you suspect somebody's got asthma, then they should be, nicest thing, they should have a pheno test, and pheno test results should define spirometry, peak flows, or other objective testing essentially. So that's something, obviously it's something that is evolving at the moment in BHR, but quite helpfully. So thanks for that, Rami. So I mentioned to you about the risk assessment. Now, NICE has said and defined these bits about risk assessment. I'm actually not sure because they're not clear about what you do with these patients. So what they're saying is, if you've got an adult who you feel is greatly increased risk because they've had previous asthma attack, you're not going to teach them more than somebody who's never had an asthma attack. You probably will give them the same information and same where to get help, etc. But they've helpfully or not helpfully just said that these are the categories of patients who are at increased risk, which actually is a majority of my patients. So again, I just wanted to put it out there. So just that when you are speaking to the patients, just be aware that these patients are at increased risk of in asthma sort of attacks, and they might need either close monitoring or different pathways within the system. I know in our practice we've got patients who've been told they are brittle asthmatics, that they've got a code that they would just get in straight. So you might need to just consider what you do with these risk assessments within your PCN and at the level. Just wanted to put it out there. But personally, when I looked at it, I thought, okay, or I'm not sure what I'm going to do if I know you're at increased risk. I would probably, uptight your treatment and give you advice as I would to any other asthmatic. So just so you know that there is a risk assessment requirement during annual review as highlighted by NICE. The next slide, please, Paul. Okay, so again, this I think is important. And again, some of these patients might not end up in your list or others, but if they're mentioned to you, or if you by chance they're seeing you for something else and they mention any of these, then they require an earlier review. So when I said to you, you will do an annual review, absolutely. But there are patients that you might need to review more than annually. And these are patients who've been to A&E. These are patients who would say to you that actually I'm getting worse. These are patients where you have frequent medication requests. And again, this should come through when you do your assessment during annual review. But if you find that you've now had the 10th salbutamol request within 2 months, you're thinking, what is wrong? So you need to do a review. Okay. Now also, the NICE is saying that you review the inhaler technique at every consultation related to an asthma attack. And the question is, again, is it being done in A&E properly? Probably not. And that's where some of the system failures occur. And when there is a deterioration in asthma control, when you're giving a new device, every time there's during annual review, and if the patient says, actually, I'm not sure, can you please check it? That's when you check it. Okay. Again, whether you do it face-to-face, whether you send them videos, whether you do use your video function that Mohammed has kindly now shown us and demonstrated that is doable with the patients. You decide as a PCN how you want to do. But the point of this slide really was that you will do an earlier review on patient and a full review as you do with annual, if they've been to A&E, if there's self-report, and if there's frequent requests, not just wait for that annual sort of check to be done. So I hope that's clear. And I think most of the practices are probably doing it anyway, or I should hope. But a lot of these patients might end up on your list because they've done the control and they're now under control. So they've passed it on to you for review and inhaler techniques. So the next slide, please, Paul. So what would you now, this is something that I want you guys to just tell me. So when there is a flare up, what do you tell the patient? What would you say to the patient? And just, I've given you some pointers, peak flow, action plan, triggers, urgent symptoms. So what would you say to the patient within that? So what, if a patient says, oh my God, I've got an asthma flare up. How do you support the patient? What would you say? Remember I said to you about the peak flow. Anything anyone wants to add? Yeah, Rami, absolutely. But I don't want you to answer, Rami, because I know you know the answer. Anyone else? So, you know, just think about what I've said before, that what are the triggers? So you check with the patient, what's caused their asthma? Are they under stress? Because actually they need help there. So you do make a, you know, what is it? Have they started working in a factory that's, you know, involves them painting? So you're not, you know, if is it hay fever? Are they expecting every year this happens? Fine, you need antihistamine. So it's not just saying that you've got triggers and that's fine, just avoid them. It's about supporting them to identify and then support them to minimize those sort of trigger exposures. But also, what is the normal peak flow? You know, what is a peak flow now? And what does the action plan, which is what Rami's put down, what does the self-management plan say? What should they do? And actually, you're reiterating the urgent symptoms to the patient. Yeah, you're saying to the patient, if your peak flow falls below the 50%, 30%, whatever your personalized target is, you can't breathe, you've used your inhalers and it's not working, you know, you need to call 111. So you reiterate or 999, whichever the case may be, how urgent they are, and you reiterate that. So you listen to the patient, but the point of this slide really was that you look at the triggers, look at what their peak flow is, and as I said to you, most of the patients that were coming to me didn't even know what their peak flow was because they've never been told how important that is. And you refer to your action plan. If they haven't got an action plan, that then requires for you to actually arrange for the patient to be seen to develop that action plan. So next slide, please, Paul. Yeah, and Todd, really helpful. You've mentioned about the history and recent and more recent history, but obviously overall health as well. Absolutely, is the obesity and all the other factors of smoking, passive smoking, etc. Okay, so I wanted to just run through an action plan quickly. I'm not expecting the low sort of pathway group people to be making an action plan. That should have been made by the medium and high risk. But what does an action plan look like? So an action plan would tell you based on the symptoms and the peak flow of the patient what to do. And it's 3 zones. One's green, yellow, and the red zone. Okay, so they tell you if the peak flow is over 80%, absolutely everything is going 80% of your expected. Okay, so if your peak flow is 500, it should be 80% over 80% of the 500. That's just normal. You'd carry on. Then if it falls between 50 and 80, you may be getting an asthma attack. That's the time. And that's the crucial period, if I may say so, because you cannot go from green to red without passing through yellow. And if at yellow, you actually try and take the steps that you've, as per your action plan, then you'll never reach the red. Do you see what I mean? So really, for me, the most crucial bit is the yellow bit. So that's what you need to really be focusing on. NICE does say when they've got an acute attack, they've got slightly different figures. But you know what? This is all personalized, because when I say 80%, I've got a patient who I know because he works with in one of the bread making factories and he's got occupation. I know as soon as he hits peak flow about 75, 78, he is already in the, you know, in the yellow zone. So I need to, and he needs to act fast. So this is where the personalization sort of comes in. So you can't have hard figures there, but just you have to, you know, gauge by the patient's symptoms. So just the next slide, please. I put here the action plan, and I said to you there's in different languages, but this is what an action plan looks like, which actually is really informative. And of actually all the chronic diseases, I think this is the one that really is so clear in what the patient should be doing. And this should have been filled out by the medium and the high risk group. And it tells you in the green zone, and I mentioned to you about the green, yellow, and red zone, and you cannot pass from the green straight into the red zones. You've got to go through this yellow or orange, whatever color you want to call it, zone. So here is where you actually stop going to red, and then you reverse back to green. And it tells you what your peak flow is, what's the color of the inhaler, and how many times you take it. If you're on a reliever, how many times you take it, and actually tells you that you take, you put that down, you take 2 puffs of my reliever, if I'm wheezing, tight stretches, and I'm finding hard to breathe, other medicines like hay fever tablets, etc., for the asthma, or any other oral medication that you take for your asthma, like Montelukast, etc. And it clearly defines what you should do. So as soon as you reach the orange zone, it tells you my symptoms are coming back. I'm waking up at night. It's not letting me do my usual work. And I'm actually using more of the, blue inhaler or whatever. And the peak flow has dropped to below whatever. So this is for the patient. And then it tells you what you should be doing. So if you haven't had a preventer, you start using. So it tells you how many puffs you should take, how frequently you should take, and what's the maximum. And if you don't get any better, then you contact the GP in 48 hours. There will be some brittle asthmatics who deviate from this, i.e. as soon as they are within 12 hours, we'd expect them to call us. But that's few and far between, and that's where personalization of the patient comes in. And then, of course, you get to the red zone, but it really, again, clearly defines what the patient should be doing. So your responsibility within the green zone is to actually look at that pathway. Make sure firstly patient has got one. If they do, patient understands that. This will be filled. You just go through the patient and tell them what happens if this, if you are getting worse. How would you recognize, and signpost to them? I often, when I do these action plans, I'm almost writing on this to underline things, because I'm making it more personalized for the patient and saying, actually, if this happens, you do this. And again, you've got a bit about the steroid here as well. So really, and there's different types of inhalers. I like the Asthma UK one because it's really straight. I think it looks really friendly to the patient. I love the colors on that. This is not the time to talk about the different types of inhalers, but there are some inhalers like the Mart inhalers that work as both the reliever and the preventer as well. So but that all will be written down by the person that's made the action plan, and your job really is to go through the action plan with the patient. And I would highly suggest that the first time you do it, if you've never done it, speak to the person that's filled it out and see what they're telling the patient, so you understand how then to explain it to the patient as to what it is. And I'd planned to do a little exercise today, but I just couldn't find the right sort of time and the plan to do this on. But do have a look. The next slide, please, Paul. And it's all on the Asthma UK website. So please do just next slide is fine, Paul. So just to please download them in different languages and give it to the patient, because it will be in different languages where you can put the numbers, etc. Again, just a quick one about acute flares, and for you to recognize history is important. And I've said to you before, if they say they're coughing, they're wheezing, they're not sleeping at night, they're not able to do their sort of day-to-day work, all those symptoms that meant to be no, they're all yes now. Because you may be encountering a person who's actually come to you for a review, but actually has got a flare. So you need to just make sure you get help. You start doing the saturations, pulse, heart rate. So actually when the clinician or whoever's responsible comes in, you've actually got that data to say, they are, they've had a history of 5-day history of cough, cold, whatever. They can't breathe, they're wheezing, they've taken blue inhalers, and actually the saturations, there's the pulses, there's heart rates, they're not able to talk in sentences. If they've done the peak flow, and they obviously, you can hear a wheeze, they're using their muscles, or sometimes if they're really bad, their chest is silent, and you would know they're persistently coughing. So a lot of asthmatic in that sort of yellow zone are coughing. So they're in that zone. You need to get help now. You know where your oxygen nebs and spaces are. Obviously you can't do this on your own. I'm just telling you this, so if you encounter somebody, you need to get your gears ready and start thinking about getting this patient ready to be sort of handled by a clinician who's has got the skills too, but you're getting that background baseline sort of work then and hanging around. So this is what the low risk pathway people would be expected to do. But again, just signs and symptoms I've mentioned here already. So I hope that's clear. I'm just going to stop at this point and see if there's any questions that I cannot actually see. I can't even see the chat function now for some reason. Okay. I can actually now. Right, great. Thanks, Paul. The next slide, please. There's nothing on there. And again, just guys, please
one thing to mention to everyone, and what you've described is the gold standard asthma action plan. And we very much hope that patients have it, they haven't lost it, etc. But at a very minimum, you can just ask patients, do you know what to do if you get worse or you feel worse? And at least that knowledge, if they're not using their spacer, use their spacer. If they're not using their steroid, use it. If they are not using their steroid inhaler, to sort of double it. So at least they have some knowledge. That will at least be better than nothing. And if they can remember that, that will help.
Absolutely, Mohammed, but I've got to reiterate, every patient should have an asthma action plan. I can't really stress that enough, because most of them go straight from green to red without actually going through that yellow zone, and you just can't do it. But you're right, Mohammed, as the least they should know what to do when they are worse. Absolutely, it's a good point. Right. I know it's been long, and I've only got on this occasion, I think for the other ones I had about 10 case studies. For this one I've only got, I think, about 5 or 6, I can't remember, maybe 5. So easy peasy. So again, this will be really straightforward for people that have been listening today, and it's really basic, but either you answer in the chat function or speak, up to you. So we've got a 45-year-old who's been coughing for the last 3 months, no other medical issues. He wonders if he's got asthma. So what questions would you ask that may indicate that he has got asthma? What would suggest asthma? Just remember what I said right at the beginning. What are the symptoms of asthma? Absolutely, Jaspreet. So nocturnal cough, fantastic. Really, really good. Yeah. Anyone? Nighttime symptoms? Yes, absolutely. So it's the diurnal variation. It's a variation that we're looking at. Variable, Georgia, absolutely. Cough, wheeze, breathless, fatigue, absolutely. Does he wake at night or not? Absolutely. Yeah, Jaspreet, very well done for remember the occupational. What does he do? Great. So I think you've got most of the answers there. Fantastic. Do you want to add anything else, Mohammed? Do you think you've got everything there? I think we've got mostly everything.
I think so.
Yeah, no, fantastic. That's great. I mean, sometimes asking for triggers is helpful, as I mentioned before, because that may give. Rami, I told you, you're excluded. Okay, all right. Yeah, that's great. Yeah, weight is something you want to know. Absolutely, Todd. I haven't given you because I've left it very generic. So you want to know if they're overweight and obese, because that is definitely a factor. Okay, the next slide, please, Paul. Thank you. So well done there. So we've got a 35-year-old male asthmatic. He asks you how he can prevent an asthma attack. What do you tell him or ask him? So he's come for a review. He says, I'm absolutely fine, doctor, but I actually don't know what to do. How can I stop getting an asthma attack? Amina, very well done. So you find out what your triggers are and then you avoid the triggers. But do remember, not every asthmatic has got a trigger. What else can they do? Yeah, Todd, well done. Diet, exercise, stress. Yes, Marco, you got it. Yep. Use your inhalers properly. That's, yeah, well done. Well done. Mohammed, anything else you'd want to add? Todd,
yes, my favorite,
brilliant.
Doctor, find out how often they're using their blue inhaler, because if they're using it more than once a day, then they're clearly not controlled and they will have an attack at some stage.
Yep. And Todd, absolutely. And I think I was really trying to get people to say that about the action plan is refer to your action plan. That actually, if you want to prevent it, make sure that if you're in the green dose and you're heading towards the orange zone, that you start taking action now in order to stop an attack. So well done, really. I think that you guys have got it all, really. Well done.
Jyoti, one thing which we'll discuss next time, my favorite topic, be on a MART therapy. Then you should hopefully never ever get an attack.
I told you you're leading the next one, Mohammed. I'm going to be a listener there. Next slide, please, Paul. Thank you. Okay. So this is a 56-year-old asthmatic. He's seen for his annual review, and he tells you that despite being on both inhalers, he's coughing a lot. What else do you want to know? So he's 56 and he says he's coughing, and he's telling you he's taking his inhalers, both the inhalers. So the compliance, I would assume, is there. Let's just assume for this case it's there. Yeah, technique. Lovely. Fantastic, Amina. So is he one of them that's sort of, in the air and walking through it? Yeah, smoking in the past. Fantastic. Anything else? Yep. So smoke. Yeah. Anything else you'd want to know? Do you remember I said to you, sometimes think laterally. He's on both the inhalers. He's compliant, and let's assume he's got his technique right as well. Yeah. You want to, yeah, absolutely. Start thinking laterally. You're looking for infections, you COVID test, absolutely just breathe. So you're now looking at other things that, you know, is causing the cough. Because yes, it could be asthma. It could be his inhaler technique is wrong. It could be we need to step up the treatment even more. But he is 56. So you're thinking, has he got cancer? Has he got an infection? Has he got something else going on there? Is that why he's coughing? So you need to just explore that bit in the history to say, you know, is the cough like your asthma cough? Yeah, Viren, good. ACE, has he been started on ACE inhibitor? Well done. I'm glad people are remembering the hypertension talks as well. That's great. So yeah, absolutely. So start thinking about, is this your asthma cough? Or are we talking about something else? And if it is, then we need to signpost you to the medium group or the higher group to sort of look at your medication and add in other inhalers, etc. If not, I still need you to see a clinician because there might be something else going on here. Okay. Yeah, Amy, absolutely. So ACE inhibitors would be the other medications that you're looking for. So great, guys. This question really was about lateral thinking. You know, is there something else going on here? All right.
And unfortunately, badly controlled asthma can develop into COPD because then you become irreversible damage to the lungs.
And there's an overlap. Sometimes you can get asthma and COPD together, isn't it, at that initial sort of phase. So yeah, absolutely. Right. So the next slide, please, Paul. Thank you. So this is a 25-year-old, a similar question to previous one, but I want you to just slightly think about the exact things you would be telling him. So this is a 25-year-old asthmatic, wants to know what to do if his asthma gets worse. What would you tell him? So similar themes to the one that we did previously. So you would check the, you know, you make sure he's taking it, he's compliant. Action plan, absolutely. So you refer to the action plan, you sit and explain to him that this is the reliever, this is the preventer, this is your normal peak flow. If you're getting worse, and the symptoms and sign if you're getting worse is you can't breathe, you're wheezing, you've taken the inhalers as advised and you're still not getting any better, who do you seek help from? 111, what can they do? When can you contact the surgery? If you're really worse, when do you want to call 999? And that should be all in the action plan. So actually refer them to the action plan. And if you, as Mohammed said, if there's a quick sort of a bit that you want to tell them because you want to bring them back in for an action plan, then you can actually just explain to them where they need to get if the asthma gets worse. But equally, what you don't want is a patient ringing you every time they start getting slightly wheezy without doing a self-management. So this is purely about making sure they know when to contact you as per the action plan, which is why I keep reiterating the fact that the action plan is really, really crucial and key. Mohammed, in your experience, how many patients do you think get an action plan that is very clear or they understand?
It's an increasing number, but at the moment it's very low, especially since we've been through COVID while cough was suspended. There's been a big reduction. And the other problem, the thing I was trying to mention earlier is that if they lose it or they don't have it or they can't find it, at least if mentally they have a minimum knowledge of what to do, which could be as simple as double your steroid inhaler or start using a steroid inhaler. At least that bit they can remember. So, but yeah, it is a low portion. We just hope that with the Liz and with cough and everything, that it'll get much higher than that. Yeah. I would say 25% can remember it.
Yeah, no, absolutely. I agree, Mohammed. And that's what my experience. And it maybe we'll need to run some session on what a good action plan looks like and, you know, how to personalize to a patient at some point, maybe for the medium and high risk groups. Okay, great, guys. Next slide, please, Paul. Almost towards the end, you'd be all very pleased to hear. Okay, so this is a 35-year-old LD patient who attends with mum. Mum tells that she's tried hard, but is unable to use the inhalers. What can you offer? What do you do? That's fine, Rachel. Thanks for coming. So this is an LD patient, and you know, some patients with LD will not have the, even with the spacer, they, you know, they won't. What would you do? As a minimum, I think, offer spacer. Yeah, absolutely. As a minimum, you offer a spacer, and there will be some, you know, that don't. And that's where the concept of personalization comes in. So you've got to personalize the care, but equally, you've got to make sure that you made reasonable adjustments to these patients as well. Yeah, personalized care, exactly. Contact the LD, just breathe, very well done. So contact the local CLDT team, because they may have some communication aids and support they can offer, so the patient's then able to take the inhaler. So to get help, essentially. And absolutely support for mum, really great, yeah. Because if the patient is obese, they can't go and exercise because they get breathless and they stop. You're in a catch-22 really. So unless they take the inhalers, they won't get better. So really start seeing more than the asthma, start seeing the support and the reasonable adjustments that you're going to make to this patient. Okay, so really well done, people, for thinking about that lateral, you know, laterally. So the last, I think, case study.
So
next
we could
please.
add that perhaps if Montelukast hasn't been tried, then that might be an option in their case. Spacer with a mask might be an option. Making it a bit of fun and into a game sometimes helps as well.
No, absolutely, Mahmood. Yeah.
Trouble.
And actually, the CLDT teams won't know about the inhalers, etc., but they will be able to help with the communication and the aids, etc. So they're absolutely. But Mohammed, you're absolutely right. Sometimes colorful, and there are some colorful things that they can be done, and that's visually attractive, and that often helps. So just get help there. Okay. So that was actually the last case study. So well done, you all. This is just a self-assessment that we did before, and just to run through the answers. So asthma and COPD are the same. No, they are slightly, you know, different conditions really. Although asthma and COPD can overlap, and then that, in particularly in smokers, asthma can then become the COPD, but they are actually slightly different conditions, treated slightly differently. So no, they are not exactly the same. Cough is not a feature. Actually, it is a prominent feature of asthma. You know, the nocturnal cough is a prominent feature. Stress may make asthma worse. Well, actually, you can now say stress makes any and everything worse. So really, anything can get worse with stress. And is the importance of, you know, making sure that the patient is signposted to the right help, support, particularly around anxiety. Because if they're anxious and getting panic attacks, we sometimes, and I've got a patient who I never know, is this asthma, is this, you know, is this anxiety? So you have to get them better from the anxiety point of view, because see what's left for the asthma symptoms, which actually in this case, nothing. So eczema in family may increase risk of asthma. Absolutely. You remember I mentioned to you about the atopic march, or patients with atopic conditions, or the allergic kind of conditions, and they all sort of group together. And so yes, there absolutely is, there's an increased risk. So all asthmatics should be blue and brown inhaler? No, not really. So the asthmatics that are symptomatic should be, if they've got no symptoms, no, they don't need to be on both. Not all of them need to be on both the inhalers. Asthma deaths are rare. Actually, no. We've got in BHR, we've got even childhood asthma deaths. So poorly controlled asthma is still killing people. Just bear that in mind. So Rachel, the technical aspect of stress is that, so it's a fight or flight reaction. So what stress does is it starts to shut down the system. So it reserves, it sort of gets the body to keep the reserve. So your lung functions reduce. So that's why asthma symptoms can get worse, particularly if you're predisposition of asthma. You can get bronchoconstriction with that. So that's the mechanism really. And we know all the other conditions, there's different sort of way stress works, but actually literally every condition can get worse. But that's the mechanism in asthma. Action plan should be given a diagnosis? No, I mentioned to you that actually action plan changes. So based on the circumstances, based on the symptoms, if you've got a patient who keeps getting admitted, keeps getting steroids, your action plan might change to the levels and when they need to seek help. So no, it can't just be at diagnosis. It should be reviewed every year. And then if they've got a hospital admissions, etc., then you might need to review. May not change it, but it needs to be reviewed. And asthma control should be reviewed only once a year. As people who've done MCQs, they would know if there's an only, the answer is wrong. So I've mentioned before, the asthma control should be reviewed if they've got any admissions, if they've used steroids, if they self-report, and of course annually as well. So if you just mark yourself on that and see where you got to.
Jyoti, I would just add that prevent inhalers are not just brown. You could have combination prevent inhalers, which can be yellow and pink, like the Foster. So
yes,
anything other than blue.
Yeah. But equally, not all of them have to be on both the inhalers. So yeah, thank you, Mohammed. Right. So I am going to, I think just the last bit is about polling. So I think it's the end now. I'm going to open up, we've got about 7 minutes. We've already mentioned, Rachel, we've got a session going on inhalers only, and Mohammed has kindly put in the dates for that. I don't know, Paul, if you're able to put that slide on again or share, but if you put the confidence poll now, whilst you're putting your questions, please can you do the confidence poll as well? So this is pre and post. If you feel slightly more able. So this is purely not about managing, it's about your role in the low risk pathway as to what is expected of you. There will be some hands-on training for some of you, but if you have a good idea of what that should look like, then please rate yourself. And also, yeah, Rami, absolutely. I think menopause, again, one of those things that can cause any and everything, isn't it? Okay, so if you rate yourselves now, and what we'll do is, Rachel, we'll take your name down, and Paul, would you mind just sharing, because Rachel might have missed the first bit when Mohammed was mentioning about the inhaler workshop.
Yeah, I'm going to put
the details.
I'm going to put the link in the chat after the poll.
Yeah.
So we've got 13 out of 17 responded so far. Just give it a few seconds more.
And good. It went up from 14 to 17. That's good, Jyoti.
Oh yeah, I mean, that's
a late surge.
Yeah, I know. So I think Rami, did you just want me to say something about the? So actually, for women, it's not just menopause actually. So perimenopause, pregnancy, premenstrual, puberty, that can all trigger asthma. So it's just, again, if you guys are aware of that they're going through, then just that's where personalization sort of comes in, that you might have to suggest to them that if they're getting symptoms, they might need to consider adding another inhaler to just stop it getting worse. Okay, so okay, great that we've got some late ones as well, Paul. So definitely improved the score, hasn't it?
Absolutely, yeah.
No, fantastic. So that's great. Right, so any more questions, guys? So Rachel, yes,
I think everybody has done so well, Jyoti, that they should join us for the medium risk workshop now. So
no, I mean, I was going to say, I think, Mohammed, that I personally think even if you're not delivering a pathway, you need to know what the other person will be delivering so you can then signpost the patients. So it'd be nice for you to attend the medium and high risk pathway, which is, I think, I can't remember when it is, in a couple of weeks or something. Then please do, because that would guide you. There's something about overweight, Rachel, absolutely. I mean, there's no question about obesity and exacerbation of asthma. There's a clear link there, which is why I said, actually, just try and see if you've got an obese patient, try and minimize the risk and refer them to digital weight management or either local exercise, whatever your local pathway is, to help reduce the weight. Todd, about breathing exercises, yes. Mohammed, what's your thought on that?
I suppose
nothing on nice. Yeah, nothing on.
Nothing. It's not evidence-based, but I suppose worth a try. Anything's worth a try.
Yeah, but again, I think, Todd, that shouldn't replace the action plan. If it can be done in conjunction and if it helps, why not? We know it helps with anxiety and some of the panic attack sort of symptoms. So if that's what's triggering it, then why not? Absolutely. Yeah, absolutely, Todd. Complimentary, for sure. For sure. Okay. So last 2 minutes, any more for any more? Rami, did you want to say anything? Because it's your PCN that's doing it. So I'm just clarifying, getting the pathways ready and etc. Rami Hara, where are you?
I think we'll need to tell Rami to increase uptake for the next workshop at his PCN, because so far the 2 attendees are not from
No.
Rami's PCN actually.
Oh, right. So, okay. Rami, if you're there, we need more people coming from your PCN because your PCN is the one who's doing the asthma. Okay, I think Rami's either his thing, internet's not thing, or he's actually gone, but that's fine. Right. So lovely, guys. Really thank you for coming and for being so interactive. It's been really helpful having you all. I hope you enjoyed that session, and do attend even if you get highly bored with all the medical language that we're going to use in the medium and high risk, but do attend just so you know which patients you need to then send over to the other area, other pathways, and what the other pathway people will be doing. So the next meeting will be more about stepping up the treatment. It'll mainly be about treatment, really, the kind of inhalers and treatment, and complementary that Mohammed has already mentioned, the inhaler workshop, which you guys can attend. So thank you ever so much. I'll let you go a minute earlier. And thanks. Paul, did you want to say anything about the offer, the motivational interviewing and or have you said that already?
You can do. No, we've sent links around for the Making Every Contact Count and motivational interviewing. I definitely recommend the motivational interviewing for the kind of conversations you're trying to have with the people you support. And I've already mentioned the video group consultations. We'll be speaking to each individual PCN lead that's taking part in this to really try to embed the value of video group consultations for supporting this work. And I've put the link and the details of the inhaler technique session in the chat.
Right, guys, lovely seeing you all or hearing you all or typing you all. I don't know what to say in this sort of IT world and new world, but thank you ever so much. I'll see you next week for the diabetes one.
And Jyoti, I don't think I've ever seen this before, but we have a comment saying the best ever webinar. So now that is
Rachel, bless you.
Compliment indeed, Jyoti.
Compliment
So well
to you. Compliment to you, Mohammed, because I don't get that comment.
you did the lion's share, Jyoti. So amazing how you don't flag off. So well done.
Not at all. Thank you all for coming. Take care.
Well, I have decided to come on. Yeah, thank you so much. I really want to just appreciate you guys. You have really delivered it very well.
Rachel, bless you.
Really do
bless you. Thank you.
Thank you.
Thank you, Rachel.
Bless you too.
Take care, guys. Bye. Mohammed, thank you. Did you want to just